low-cost innovations. And can you describe how your work on low-cost innovation facilitated the diversity, equity, and inclusion stimulation across India?
Thank you. First, I will rephrase Dr. Vijay's introduction. Actually, our mannequins are not jugaad; they are state-of-the-art mannequin, having features more advanced than the imported one. We will show you in a minute. And I'm MD Medicine from Vijay 91, and I'm a resuscitationist. I'm an EM physician, and I'm a regional block and focus instructor, and I'm a podcaster also. So with that, these are our mannequin. If you can look, there's an ICT mannequin, there's surgical bride, there's IO access, nerve block trainer, ultrasound guided vascular access, then we have stop the bleed, then the cat tourniquet, and then IO power driver, the needles, then central line, and then most important mannequin which India must have in every institution is the our trauma buddy, which teaches ABCD protocol. Because first we need to find the injury and then resuscitate. So this is one mannequin I will recommend every institution should have, because ABCD is the basis of resuscitation. Next one. So just the features, like this is our IO access. And
okay, you let it ABCD. Okay, stop there.
So these are the features. Like you get the simulation.
And aspirate slowly. So this is what to get if there is a normal patient, but it is severely dehydrated.
So power driver also has been designed by me and the IO needle also. So secondly, this is a patient of polytrauma with unconscious. You know that patient in ultrasound surgery from soaring. So what we have to do first, what we have to do is basically
Grab thrust.
what we are doing, and now his airway is absolutely clear. That's what we want to show the students, not like what is not happening. So objective parameter, then there is a ICT mannequin. You can see this.
I'm playing, sir.
This is the unique feature of VERVE chest tube trainer. As you can see, inflation and deflation of the lung when you are doing the finger swing.
Next one.
So that gives a realistic feeling.
So this is the nerve block trainer I have designed. This is a femoral nerve block. The rectal nerve is a vein. This is down is the artery, and there is a femoral nerve. So the needle is going from the left side of the screen, and you can see the needle. You know, the first one.
Okay, sir.
Let them see the needle actually. How you manipulate the needle or the angle or your angle with the skin. So there comes the needle, and this is a very good model. Like not only we need to set our basics right, but we need to modernize our trauma care. So regional block is the most important thing now in pain management, and that's what we do in practice, and that's what we need to teach. And the next one is the ultrasound-based vascular access. So yes. So this is a very low cost mannequins. So you can see there is a blood vessels, and then the needle is coming, and you can calculate the angle. You can practice mostly for the novices or new resident. And if you can just completely show that, we will skip the other. So these are all designed by us, and we are manufacturing also. So there comes the needle, and it is going towards the upper wall of the vessel, and now it is indenting the vessel wall, and then it will get inside. Okay, yes. So see, our diversity, equity, and inclusion, we are not there yet, like in America or Western country. Our problems are different. Like I will take you from your paper, but you have described the various barrier in setting up the simulation center. So how our mannequins are affecting the simulation scenario in India? Because earlier there was limited availability, like to the premier institute. Like we used to have like mannequin in AIIMS or some other institute. But now there is widespread availability. We are going and training doctors as far as Siliguri and Vijayawada, and our mannequins are being used in ATLS courses. And let me tell you one story, like the AIIMS Bhopal, they had their ATLS program, but they could not get any mannequin. So they phoned me, and I rushed the mannequin overnight. So their ATLS course, inaugural course rather, would be completed. So now we don't have to depend upon the imported brand. And our mannequins are almost like 40 to 50% of the course of the imported brand. Then the Liverpool faculty comes in India, they do that ACCC course, that's an acute care course, a critical course for surgeon, and they are also using our mannequin. We have been to Bangalore, multiple places. So barrier like between the Premier Institute and the local hospital has been broken, and now with VERVE also, like we are initiating even civil hospital doctor into simulation so that they have hands-on experience, and so this is how, like, whatever you want to break, we need mannequins. We need mannequin first, the raw material. So that's how, like, we have tried to break this barrier with low-cost mannequin. Of course, we make mannequin, but we customize also. That's what we need in India.
We just have about 2 minutes left. And so I want you guys to think about the remaining barriers. One barrier that you think is being broken, is it ChatGPT that's going to break it? Is it going to be the new fancy mannequin that's super cheap? Is it going to be, some breakthrough? Just think for a moment, and Vijay, you're going to sum up, I think, in just a moment.
Yeah, just
But
just to ask 30-second each about next steps or future directions, if they can say in 30 seconds.
future directions, but then also conclude with the one breakthrough. And I just want to preface it by saying the intention of showing these videos in the background is not to advertise any particular individual company or product. It is simply meant as examples of what some people have done. So why don't we start on your end?
I think, okay.
Who do you want?
Okay. So,
Or you want to do a
please
slide?
do answer.
We'll start with mine because the slides are in order.
Start with mine. You need no slides.
Yeah, he needs no, of course. He needs no mic either.
Yeah, it's true. Hey, look, I think the breakthrough is not going to be technology. I think it's curiosity and partnership in order to solve this. And I think, I guess our next, certainly in my world,
something we need to have a mass solution. So gamification of the healthcare, like I have tried to design an application where we are teaching trials with the mobile application. So if they do the trials, then they move on to ABCD, and if they don't, then the game restart. So while playing, like they are not on duty or they are like need not to come to the center to learn this technique, they can learn through the mobile application. And secondly, we need to have like mobile units, like in polio. Like we need to go to, let's see, India mentality is different. Like it's not like they will come and get trained, but in India we need to have some new mobile simulation lab, and then short courses. Like maybe we can teach ABCD to all the healthcare providers, and then iteration after 3 months. Because ABCD is the basis, and I have seen doctors even not following the proper protocol, and the mindset and the culture which you have talked about in your paper. We need to change mindset and the culture of our even medical fraternity. Like the perception is like we can learn because there are so many patients, and what is the need of simulation. So of course with patients, for patient safety and less medical legal and less violence, it is better that we should have these short courses and a mindset and a culture of simulation embedded in our medical curriculum, like simulation-based medical education, and that can be accomplished with low-cost mannequin. And thank you.
Yeah. Rashmi, Rashmi wants to say something?
I just remembered something which happened.
So the theme of the next session is building the future of next generation of healthcare team. Now we have the panel discussion on competency-based simulation curriculum, NNC guidelines, and more. So the moderators are Dr. Ibor Jacob J. and Dr. Arijit Das sir. The panelists are Dr. Ashok Devrani sir, Dr. Somshekar Nimbalkar sir, Dr. Lulu Sheikh sir, Dr. Archana ma'am, Dr. Niti Pinto. And now I hand over to Chase for the further proceedings.
Okay, so we're moving to the next session. I like to invite the moderator for the session is the Dr. Jacob James. Dr. Ibor is the head of the PICU unit of the CMC Fellow and the present president of the Pedistars and also the vice chancellor of the Pediatric College of the Pediatric Critical Care of India. And I think I hand over Dr. Ibor to have a panel discussion on building the future of next generation healthcare team, competency-based simulation curriculum, NMC guideline and more. Over to you, Dr. Deep.
Thank you. Thanks, Dr. Mihir and Chair for introducing us. And thanks for the opportunity. And as we know, we are running late by 1 hour. We'll try to do justice to this panel discussion, which is very important. I thought the topic is as well, building the future of the next generation.
What's your name?
My name is Amar Chauhan.
Nice to meet you.
Nice
What
to
do
meet
you think your biggest takeaway or something that you learned from the conference?
The biggest takeaway is like we need to create mindset and the culture of simulation in India, because I am a medical innovator. I have designed manikins and they are not being used and people are dying. We have the highest death rate in road crashes. So the only way to bring that down is to have simulation and be proactive. Like in trauma, you are alone and sometimes you are unconscious and you are not able to tell what are your complaints are. So there we want to train doctors on simulation, especially my field is trauma.
And what do you think is the biggest barrier to doing that?
Again, these are cultural things, your values, your belief. So in India, because of the poor infrastructure of the medical or the poor medical facilities, and plenty of patients, like our Indian doctors, they tend to learn directly on patients, right? So they don't have any experience about the simulation, and that's why we have so many casualties. But we usually don't account for them, and the scene goes on. But now, because of the awareness, like people are asking, like what was the diagnosis and what was done at that time and what was done next time. So how it happened, like it happened in USA, it has to be time dependent. So we usually don't do time dependent resuscitation or the treatment. So they are learning on patients in the government hospital, because we have too many patients. Like you can learn, but there is no patient safety. You can harm the patient. Where in mannequin, like this is the biggest point. Like without harming, you can learn at all, and later you can replicate it in clinical scenario. So more patient safety.
That's a good answer. Thank you so much.